Thanks. Hi, everyone. I'm Stanley Brown. I'm the Dean of the Dalhousie School of Public Health at the University of Toronto. And my job today is to say as little as possible and let our panelists talk for a lot longer. So why don't I introduce our panelists, bring them up, and then we will start right into the event. First, we're supposed to have Anthony Dale here today, but we have the newer and better version. Melissa Procopio, Vice President at the Ontario Hospital Association. We've got Will Falk here, who's the Board Chair of AMS Healthcare. Laura Rosella, who is a professor with the Dalhousie School of Public Health and also Trillium Health Partners. Alison Secula, who's the President and Chief Scientist at the Baycrest Academy for Research and Education. And Jody Younger from my hometown, who's the VP of Patient Care and Quality at St. Joe's in London. So if you join me up here at the front, feel free to grab a water and a mic. I'm actually going to kick right into this and turn over to Melissa very quickly. We're here to talk today about a report, and Laura will give you a deeper understanding of the report. But fundamentally what it says is in about 15 years' time, you're going to have the entire population of Ottawa and Kingston, equivalent of that, standing in line for care, for very serious care for serious illness. Which if you think about how long it takes us to build a hospital, think about how long it takes us to train a physician, think about how long it takes us to really sort of bring on and make sort of battle ready anyone in our health system. It's a remarkably short period. Now, the challenge with any projection is that things change. The first piece of work I did, or actually looked at on projecting need, was around heart disease. And we thought we need a lot of cardiac surgeons. I'm going to show how old I am. Cardiac angioplasty came along and changed that number dramatically. We needed a lot more interventional cardiologists and a lot less cardiac surgeons. But the basic point that in the analysis likely rings true under any scenario, that need for care, serious need for care is going to increase. And there's relatively little that we can do to change the increase in need, but there's a lot that we can do to change the way that we meet that need and the way that we kind of modify and mitigate some of those challenges. So with that, maybe I could turn first to you, Melissa, to talk a little bit about why the OHA commissioned the study. And a little bit of an idea about kind of what's driving your sense of the current landscape around this.
Sure. So thanks so much, Fanny. Good morning, everyone. So, I think we've had this conversation now in a couple of different circles, but we emerged from the COVID pandemic, I think collectively with a renewed sense of optimism. The sector, the system, frankly, put forward, Herculean efforts to meet the needs of the population, to prevent COVID, to treat COVID, to just deal with the situation in front of us. And we were able to do that and to provide timely access, better, more appropriate care. And so we were excited. We were optimistic that the ways that we had done things during COVID would actually kind of propel us into the future. We approach things differently. We worked outside of our silos. We just got it done. And I think we really saw this as a turning point for our system for the future. And so we were disappointed and surprised when we started to notice that every part of the system was slowly shrinking back to the status quo. People went back to their siloed corners of doing and thinking. And so much of the progress that we had made during the pandemic seemed sort of futile. And so we paused. We took a long pause with the OHA and we started to ask ourselves, why is this? And more importantly, why do we care? Why do we care now? And why is it more important for us to start thinking about this in a new and a different way? And it was at that time that we actually came across a study out of the UK from the Health Foundation, which started to look at what the future of their population would be. So they looked at epidemiological data and they looked at population data, and they were able to project out exactly what they could expect in their country in the next 15 to 20 years. And the results were staggering, shocking, concerning. But it was the impetus which really drove future conversations about why we need to change and why we need to change now. Because, if you've heard our message or seen our message over the last year or so, I think what you'll appreciate is that we're embracing the concept that the status quo is no longer an option, and that we really need to think differently and work more collectively to actually prepare to what Steny alluded to, which is our population's needs of the future are going to be very different. And if we don't address it now, we're not going to be in a position to be able to care for those individuals in only 15 years' time. So I think I'm going to pass it to Laura now, who's going to talk a little bit about how we leveraged the thinking in the UK and working closely with the team at U of T to actually conduct our own work, and with some, I'll say, similarly staggering results.
Absolutely, thank you so much. So I'll just give a really brief overview of some of the color of the report and what it means for our discussion today. So we worked closely with the OHA, but I do want to mention we had an independent academic team led by Steny, myself, Monica Alexander, a demographer, as well as ATS Daniel and Emma Buijidi. So we did this work as rigorously as possible. It's the most comprehensive modeling of projected burden of illness in Ontario that we've ever had in this province. And the results are staggering, and they have very severe implications for our health system, for patients, families, caregivers. So I'll talk just briefly about just the demographic shifts that are going to happen. So Ontario's population is going to grow in the next 2 decades by about 36%, but the biggest growth is happening in the age group 65 and older. They're going to grow from 2.6 million up to about 4.2 million, and that's an increase of over 60%. So those demographic shifts alone pose a significant challenge for our system. As mentioned, we're seeing an estimated 3.1 million people by 2040, up from 1.8 million with major chronic illness. Major chronic illness means these people require hospital care. So this is not just having an illness, this is requiring hospital care, very significant resources. That's 1 in 4 up from 1 in 8. And as Steny mentioned, think about our health system now. Imagine the full population of Ottawa and Kingston show up at the door of the hospital. That's what we're talking about. The other thing is the complexity is also rising. So the number of illnesses that people will have is also up. So on average, the number of illnesses that any individual will accumulate is going to increase by 60%. More complexity with those illnesses, and obviously more demand. And looking at just individual conditions, osteoarthritis alone doubling from 1.4 million to 2.5 million. So you get the picture. Unfortunately, I don't come with good news. The other thing I want to mention, this isn't just hospital impact, obviously impacts primary care. It impacts home care. There's just no room to absorb those numbers I just mentioned. You put in a new pandemic, economic downturn, workforce shortages. There's no ability to build our way out of it or to absorb it. So there's kind of 3 implications I want to keep in mind for today. So these numbers mean first that we have to radically rethink chronic disease prevention, early detection, and treatment. So when I talk about those demographic changes that we saw, it's not inevitable that chronic diseases start at 65. Many chronic diseases can be prevented or delayed or treated early, which have much severe impact. So a delay starting a chronic illness at 65 versus 70 or 75 has a dramatic impact on individuals and our system. And we know how to do that. We actually have high quality evidence how to do this. The second is we need to think about how we deliver care and raising innovation. This includes digital technology and proactive population health management. That can't be the exception, it actually has to be the norm. And then lastly, I'll say I've been monitoring health inequities in this province for the last 20 years, and they've been getting steadily wider. The last biggest increase we saw around the economic downturn in 2009-10, and we're seeing the next big one now. And make no mistake, these burdens, these numbers will affect marginalized and vulnerable groups most. And I worry we are going to get to a point where those inequities are going to get so wide, we're going to get a point of no return. So we have to be thinking about the social determinants at the center of any policy reform. It has to be at the middle of it. It can't be an afterthought or an add-on. So I wish I could say that this is modeling, there's always a margin of error. Hopefully, we're wrong. But these results were very robust, they're very consistent with what people experience every day. And 2040 is not that far away. So this is not a future problem, this is a current emergency. And I hope that these numbers provide an impetus for change. I know we can talk a lot about what we should do, I think we should just focus on, we need to do something now. So I'll leave it there.
Great, why don't I actually just shift a little bit here, so the kind of staggering results, and as Laura said, you can't build and you can't train your way out of it. I'm actually gonna try to take us in a positive direction this morning. I'm gonna do two things. First, we're not gonna talk about tariffs, which I think should be kind of nice. A little bit.
Thank you.
But second, I want us to talk next about really kind of what the potential for success is in the system. Laura, Melissa's already pointed out that there's more that could be done. We actually learned how to do things differently during a period of crisis. Laura's talked about a variety of elements of sort of what might be a comprehensive policy solution. Maybe Alison, I could turn to you first to talk a little bit about, the shift towards prevention, early intervention, things we might do to manage care better for people who have disease and keep them sort of as healthy as possible. Maybe even talk about things we haven't talked a lot about so far, like dementia or Alzheimer's. Maybe turn it over to you first, and I'll turn it over to the rest of the panel.
Sure, thanks. And I just want to say thank you to Laura Steiny, the whole team at OHA for that report. It is a really important and timely report. And one of the things it does highlight is that the population is aging. And as you get older, your chance of dementia does increase. And we are currently living with about 770,000 people with dementia here in Canada. And is expected to more than double by 2040. And worldwide, someone somewhere in the world every 3 seconds is diagnosed with dementia. Here in Canada alone, it's right now somewhere like every 3 to 4 minutes, someone is diagnosed with dementia. By 2040, 2050, it'll be once every 2 minutes. That is if we don't change course. And this is where I think we do have some positive news. There is an opportunity for us to focus more on prevention. So in the days when I was growing up, if somebody had cancer, they didn't talk about it because there was almost nothing that you could do about it, they thought. Since then, now, unfortunately, we don't have cures or treatments for all kinds of cancer, but for many kinds of cancer, things that would have killed us 40, 50 years ago no longer are that much of a concern. My mother just had her second bout of breast cancer this past year, and when she was diagnosed, she was like, "Oh, it's not really a bad one. I'm not worried. No one needs. She lives in Boston. No one has to even come visit." And now she's fine. That was her second bout, and that is, I think, the power that we to do for aging and brain health, to do for all of these other kinds of diseases, what precision medicine has done for cancer, for heart disease and others. And this is where it gets really interesting, because this is where you can take the population health approach and kind of combine it in some ways with that precision medicine approach. I think we need to take both of those into account. For dementia, people didn't want to know, are they headed in that direction, because they thought there was nothing that they could do. But we now know that at least 45% of the dementia risk factors are things that we have control over. Modifiable lifestyle choices, things like social engagement, things like cognitive engagement, learning throughout your lifetime, things like addressing hearing loss and vision loss, things like addressing obesity and addressing high blood pressure and high LDL cholesterol. Many of those sorts of things, if you can address them for reducing your dementia risk, you're also going to be able to reduce the risk of a lot of other diseases. And in fact, a lot of these other diseases where we expect to see, and conditions where we expect to see a lot of growth according to the report, hearing loss, diabetes, et cetera, those are all risk factors for dementia. So whatever we can do to raise awareness amongst the general population that there are things that we can do to take action. And these things start not just in older adulthood, but in early childhood. So the amount of education that you have as a child actually is a predictor of whether you will end up with dementia. So it's important for us to think about the combination of the population health and what we call the precision aging approach, as well as thinking from this lifespan perspective. The earlier people can get into good habits, the easier it is for them to maintain those throughout their lifetimes. And we have a podcast called Defy Dementia that Jay Ingram, the Canadian science journalist, he and I co-hosted, where we're trying to get the word out about all of these kinds of factors. And it's really interesting to hear the stories, because what we see there is that everyone is different. I mean, if you treat any kind of disease, they always say, you've seen one person with dementia, you've seen one person with dementia. You've seen one caregiver of someone with dementia, you've seen one caregiver of someone with dementia. And so that is where it's really important when we're looking at how do we bring more of an emphasis on prevention in, that we take this personalized approach to it. Because what you need in terms of your, say, longevity prescription or your aging and brain health prescription is going to be different from what you need, because you have different genetics, you have different social environments, you have different starting points. And that's one of the things that we're doing at Baycrest and the Kimmel Family Center for Brain Health and Wellness, is to create programs that are individualized to meet each person's specific needs so that they can all age as well as possible, and get away from this morbidity expansion and move more into morbidity compression, right? So that's basically saying we want more years where we're older and healthy, as opposed to more years, which is where we're headed, where we're less healthy. And the last thing I'll just say here is in terms of the prevention side of things, you mentioned the benefits of that. The numbers are really staggering with respect to dementia. It's in part because of the nature of the disease. And so, for example, someone who's an older adult caregiver with most sorts of chronic diseases might spend about 17 hours a week taking care of their loved one. With dementia, it's closer to 26 hours a week. And about half of all of the caregivers for people living with dementia are feeling distress, which is a risk factor for dementia. Caregivers of people with dementia are 6 times more likely to develop dementia themselves, not because it's contagious, but because of distress and other factors. And they are distressed at a much higher level. They're out of the workforce at a much higher level. Right now, globally, dementia care, direct and indirect costs, is about $1.3 trillion. And by 2030, it's expected to grow to $3 trillion. For comparison, the GDP of Canada is about $2 trillion. So if dementia care were a country, it would be one of the largest GDPs in the world. That's one way to be thinking about it. So whatever we can do to minimize the impact of this, to not just reduce the disease, but to get people back into the workforce, to help improve productivity, that would be amazing. So if we can delay the onset of dementia by 10 years through these prevention sorts of methods, or slow the progression of disease, we will by 2050 end up with 4 million fewer cases of dementia in Canada. We will save 1 billion hours of caregiving in Canada from unpaid caregivers. So these are really important sorts of numbers. I think that we are in a position now where we're able to take everything that we've learned and put it to use, so that it's not necessarily predetermined. That is where we could end up, but there are things that we can do.
Quick follow-up from any of the other panel members before I go to the next question. Maybe I'm going to go to the next thing, which is how we sort of think about priorities, because there's not going to be the ability to do everything that we want to do right away. Part of that's just resources, part of it's attention, and part of it is, the whole burden of change and moving along that. But maybe Jody, you want to talk a little bit about where to focus priorities, what strategies we might have, and kind of allocating limited resources to get to the a much stronger place.
Yeah, and I'm glad we're not talking about tariffs because that could be more limited resources in our healthcare procurement life. So nice to see everybody here this morning, and what you might not know, you might think, why St. Joseph's London sitting on us precariously on our stool up here? And that is because St. Joseph's London has a somewhat unique space in healthcare as part of some of the health restructuring decisions of many years ago. We sit in it as sort of your non-traditional acute hospital space where we serve a large post-acute population. We have pretty much all of the bedded volumes for rehab and complex continuing care for the region that we serve, as well as all of the large ambulatory services attached to that. We're about 1,000-bed, 5-site organization with a very large post-acute focus and specialized focus on mental health. So we kind of sit in this space that frankly, as we've been working on our capital master plan with our partners at KPMG as part of the team, and looking at that space, we can see that let alone just our complex continuing care numbers in the next 10 years are going to double. So this is a conversation we've already been having, and the OHA report really came at a great time. We set our structure up at St. Joseph's in a very intentional way, where all of us who are kind of clinical VPs in the traditional sense actually hold a vertical and a horizontal portfolio. And the intent behind that is so that we're looking at our organization in two ways. One is sort of your vertical specialty. In my particular case, it's mental health. But I actually have a horizontal specialty that's quality strategy and capital planning. And the reason for that is we are all then threaded both into our specific topic areas, but then across the organization, which creates unique opportunities for efficiency and planning, which is sort of the MO of our future state. We have to look at our structures differently. And I'd say there's sort of two overarching themes, and these might sound like no-brainers for this audience, because it's a very smart audience. But I'm going to say them anyway, because I think it's important. One is that we have to stop thinking in our traditional acute hospital siloed, or as the report called it, single condition model. That is not the future, and if we continue on that path, and we're perfectly designed, by the way, to do what we do, we know that, it's the way acute care came about, we have to start thinking differently, and we have to lean into how is technology and innovation going to help us thread these things together. And then the second thing is that the solutions cannot only sit with hospitals and in fact healthcare. These are issues that affect all of us, business, health of cities, everywhere. And so the solutions have to start thinking outside just the traditional healthcare and even social services partners. And we have to start doing things differently. And there's an interesting spaces. I don't know for folks. I know there's some Nova Scotia folks in the room. Nova Scotia is doing some really interesting work. They have a health innovation hub, and I'm going to read one quick sentence from their hub's purpose. It says, through strategic partnerships with patients, families, clinical champions, industry, healthcare foundations, governments, and academic partners, you're working to transform healthcare through the best available evidence and well-researched solutions. And they're doing some really cool stuff. So if you haven't heard about it, have a look. And I think what's really important message out of their work and path forward about how are we going to do things differently is not partnering without parameters. It's partnering within parameters that we know about, that best evidence, all the stuff that Stacey kind of lives and breathes. And I think that's often the worry when we start talking about public and private partnerships is that it creates a slippery slope, right? We worry about that. So it's not partnering, it's partnering with parameters. And just to say that what came out of the recent capital master planning that we're just about to sort of sign off and dot the I's on, of course, it makes sense that we talk about technologically enabled care, alignment of services for impact, both internal and external impact, planning for complexity from a patient-centered perspective. We can't be siloed. These are not kind of new principles, but these are what came out of the themes, and KPMG is really doing some incredible work in this space. And so when we talk about a call to partner differently, I just want to give you a quick story of a recent announcement that we had at St. Joseph's London just a little over a week ago. That's kind of a landmark announcement partnership with WSIB. As I sit precariously and risk musculoskeletal injury, I want to talk about this because we talked a lot about dementia care, But musculoskeletal injury, and irrespective of workplace or not, has one of the most significant impacts on long-term risk and health risk for people. So just a few quick stats. Mobility disabilities are the most prevalent disability, 1 in 10 Canadians over the age of 15. And that reduced mobility has basically causes 8 out of 10 of significant predictors of poor health and life quality. We look at just the WSIB figure, we have 250,000 claims a year, and about 13% of those claims do not go back to work within 3 months. And we know the stats after 3 months, 80% of people that don't go back after 3 months don't go back at all. And that once pain becomes chronic, that 94% of people do not respond to our traditional kind of treatments for pain. It becomes a lifelong issue. And I bet you everybody in this room knows at least one person who's chronic pain, which has a huge impact on mental health comorbidity, addiction risk, as well as other quality of life indicators. So just that alone, what was really exciting about this announcement with WSIB is that our partners are helping us invest in creative digital AI-informed solutions for the future. So we've already, through our Gray Center for Mobility and Activity, Siobhan Shabrun, who's our lead there, she already has done some incredible work around brain biomarkers, actually being able to predict potentially people who may convert into having chronic pain. So to start to sort right when you first appear with that acute injury, whether you have a higher risk of converting to chronic pain, for example, and some super cool technology that we're very excited to get to share. Computer assisted rehab, looking at how AI interface, creating kind of that metasphere, which allows you to interact with researchers from across the world. So super cool stuff. It's a great example of the kind of partnerships you have to do. It took us about 6 months to pull that proposal together because WSIB kept telling us to think bigger. The other thing I just want to focus on, which is sort of the other end of the spectrum, sorry, Mike, the other end of the spectrum is ALC. So I'm going to plant this seed. I don't know if anybody else in the panel wants to pick it up, but it's not unsurprisingly, anybody here who works within a health and hospital environment, a big conversation is ALC. And the focus is about reducing ALC. Reduce it, diminish it. ALCs, we know, is a complex situation with a large number of people who need sort of higher supports through a long-term care environment, and a much smaller number of people with a much larger proportion of bed days who have an incredible array of, if you know one person with dementia, you know one person with dementia, array of needs. And the focus on, I would love to flip the concept of reducing ALC on its head and talk about increasing a whole spectrum of services for people in the community to meet individual needs that cannot be met in a sort of didactic hospital, home, or long-term care environment. So I think it's really important because for hospitals, it's such a huge conversation. For us, during the pandemic, we opened a large number of quote-unquote ALC beds. And through that, we really, really learned about some of the needs of the population. And part of the work we've been doing through our capital master planning is trying to define what is the type of environment of the future where we need to support individuals who have the higher complexity of needs, who may not be able to fully return home. So maybe people don't want to pick up on that thread, but I see Melissa put her hand up. I'd love to have that convo.
Let me sort of shift now to sort of talk about this opportunity for collaboration, for changing the sort of balance of care in the community. Maybe Melissa, you want to start? Will, you'll come in maybe after that.
Yeah, I was just gonna say, I think, picking up on what you were alluding to, Jody, I think we did so well during COVID because we worked in team-based models, both formally and informally. We focused on the patient or the problem in front of us above everything else. And we took some calculated risks. And I think we have the ability and I think the desire now to do the same thing. I think, Jody, to your point around ALC, I like to think of ALC, the solution to ALC is a system solution. It's not a hospital solution, it's not a primary care solution, it's not a home care solution. Hospitals would love to reduce their ALC numbers, but that is dependent on having access to services outside the hospital.
Right.
And so, one of the things, we're embracing at the OHA, and I would encourage everyone to think about, is this concept of civil society. the civil society really, effectively means doing what's right for the community that you serve. It may not necessarily mean enhancing services within the four walls of an organization. It may mean promoting things in the community that actually reduce the need for people to come to the emergency department in the first place. And when we start to think about what's right for the community and what our role in civil society is, it makes me think that that was the approach that we took during COVID that made us so successful. We just focused on what was in front of us and we stopped worrying about where we sat within the system, what the silos and the hierarchies were. And we had decentralized decision-making that allowed us to just move dynamically to address the needs that were right in front of us. And I'm optimistic that we can do the same thing again, because to Laura's point, we now know the why, we need to have the desire, and we have the ability and the technology and the innovation, both with us now and emerging to really move forward into the next generation of care. And so I think optimism for us is an opportunity to move forward because we have no choice.
Hi, I'm Will Falk. I'm the volunteer board chair of AMS Foundation, and I'm here replacing Helen Angus because of the caretaker rule, which is why I'm wearing jeans. I was in New York when I got told that I'm doing it. So I'm delighted to be here, and as it turns out, I was needed for all kinds of reasons. I am, some of you in the room, so first off, AMS invests $4 million every year in grants and fellowships of two areas, history of medicine and artificial intelligence and compassion. We have granting and fellowship programs in both that are Ontario focused and cover all of Canada. We don't ask anything, we just give money away. And if you don't know about it, you probably want to. We've been doing artificial intelligence for 4 years now and fund clinical and administrative fellowships, the administrative ones with Stadium and school. I'm also a recovering management consultant, and I'm 7 years into my recovery. And during my career, I probably did 500 projects, and I'm going to say more than half of them had some kind of forecasting and planning piece to it. And so my first comment is, as a consumer, this is really excellent work, and congratulations to the team. I mean, really, this is first-rate planning work and really useful. There are, of course, limitations to central planning. Anyone who's done it knows and is acutely aware of. Forward planning of past events is tricky. We have two really big things that have been happening at a societal level, one for 200 years and one for 75 years. The 200-year one is sanitation, et cetera, that's taken life expectancy from 40 to about 80. And then we have the post-World War II trend, which has been adding 2 years per decade to life expectancy. That's what's causing morbidity and mortality compression at the top end. But let's just pause and remember that that's a good thing, right? As a 62-year-old, it is a good thing that my mortality is being compressed up to 75 and 80. What it means for you guys as health system planners is that you have a bolus coming. My first question to the planners, whenever we do 2040 compressions, is what's happening in 2050 and 2060? Because I do think that the pig goes through the python, and I do think that there is a point, and maybe it's not till 2080, when python poops out the pig, and we have a very thin python again. And we saw that happen when I was in the Ministry of Education in the 90s and 80s. We saw that happen with schools in downtown Toronto, and at some point that will happen. The other thing I will just talk about is from personal experience, two very quick ones. One, AIDS planning in the early 90s. I'm sure I did projections that had 20% of the hospital beds. filled with AIDS patients before retrovirus came in. And you made the a couple of people talked about cardiac disease and how demand changes. Demand will change on some of these conditions. It may go up, right? But with what's happening in the US, we may see infectious disease come back as we did earlier this decade. It may go down. Cancer is now a chronic disease and going down. I personally, for no very good scientific reason, believe that we're missing something big in Alzheimer's and dementia. I'm not an expert in the area. I note Topol's post this week about microplastics as being something we might be missing. There's something we're missing there, and I would be delighted personally, because it's rampant in my family, if that were true and we could find something there. I just wanted to make the point about artificial intelligence and this kind of planning. Artificial intelligence, when we think about teams going forward, I can make this in a longer way, I'm gonna make this short. Artificial intelligence is a team member, the same way that human intelligence is a team member. And as we think about these projections, I took your projections and had ChatGPT comment on it. Some of it was really good. It was crazy, but as I was thinking about it, I was thinking, is our ICES and CIHI and Public Health Ontario opening their data sets up? Are we able to get nimble projections? The problem with straight lines of death is that they get hard coded into the system, right? The straight lines of death is my personal name for central planning, right? We forward project and we get rigid. Can we introduce some flexibility in here that monitors the science and actually thinks in a thoughtful way? I think actually the answer is yes. I think a planning associate who is an artificial intelligence may end up being more nimble, and that there's some stuff that we could do. And I encourage you to think about competency-based AIs as you examine these problems, because having new team members and new supply of I can say labor, what am I going to call it? New supply of intelligence and analytical capacity could be really important as we start thinking about some things a little bit longer.
Excellent. So look, at this point, I think what we're going to do is spend a few minutes, maybe the next 10, 12 minutes, kind of soliciting ideas, thinking about what actually might be the top choice in terms of starting to get in front of this. What would be the, out of this, maybe we can generate a top 10 of the innovations that we think should kind of move forward. I'll turn over to the panel first, thinking about efficiency, but also thinking about equity as we look forward in this. And there may be comments from the folks here in the room as well about things they've seen, promising innovations that may be languishing or not getting the attention that they need. So I'd open it up now for a little more discussion about kind of what the hit list is.
Sure, I can start. One of my other hats I wear is as the president and chief scientist of the Center for Aging and Brain Health Innovation, which is Canada's only innovation catalyst focused specifically on aging and brain health. We do have a focus on dementia and other areas. We have funded since our founding in 2015 over 500 different projects. We've invested over $170 million into this kind of work. And I just have to say, in case there's any folks who care about the outcomes there, in addition to introducing hundreds of new solutions into the healthcare system, the companies and the innovators that we've worked with have now accrued nearly $750 million in follow-on funding from our initial investments. So there's a huge return on investment for all of these kinds of things. What I've seen over those numbers of years that I've been running CABI is that, yes, you see all these different sorts of technologies and solutions popping up. But what gets me most excited is when I think about the collision of technologies, how we can put them all together. So we've heard a lot about, ChatGPT is one of my best collaborators also. So
we're gonna run a prompting program.
Yeah. So there's, the AI is not new by any means, but there's been a rapid expansion of it with the large language models and generative AI. And it's being integrated into many, many more things. Robotics, Internet of Things, sensors. I mean, who here is wearing Fitbit or an Apple Watch or a Ring. Anyone raise your hands if you're, I mean, you're all wearing health sensors, right? There are now already, glasses, that Meta has and soon other groups will be having these as well, which can be not only bringing artificial intelligence into your everyday view, literally, but will also be simultaneously recording your biometrics, your brain data, your heart rate, all of the sort of the biomarkers that are important. So we can have a constant kind of analysis going on. So one of the things that is also really exciting for us is was mentioned, this opening up of the data and the sharing of the data. And I think the last thing that is interesting in terms of that sort of grouping of different elements is the ability for people to control their own data, right? So we've seen over the last number of years, more opportunity for patients, for everyday citizens to access their health data and to control who has access to those in different ways. So I think when we put all of those different kinds of pieces together, it sets us up beautifully for being able to do a lot of the kind of work that we were just talking about in terms of prevention, in terms of early detection. So in my lab, for example, one of the things that we do is we use electroencephalography to be able to determine, we think maybe, 5, 10, 20 years before somebody develops dementia, what are sort of some examples of changes in brain waves and behavior that can predict that. And we have funded a number of other groups across Canada, across the world, that are in this space. There's a huge amount in this space, but it's not going to be a one size fits all kind of solution. It's not going to be one thing that solves everything for us. So, it would be great if there were just microplastics was it. But what's probably going to be is a little bit of microplastics and a little bit of this, that, and the other thing. And I think that we now have the compute power, we now have the ability to put all of that together in really interesting ways. But it's going to require each and every one of you and everyone we know thinking like entrepreneurs, right? Getting out of the mindset of the healthcare system, where I came out of the university system into the healthcare system, and I thought the university system was hard to deal with. It is very difficult to get anything done in the healthcare system because it doesn't think like an entrepreneur. It puts risk first, which is obviously important, but to move things ahead, we, as I think Melissa was mentioning before, we have to sort of change our whole mindset. We have to reinvent the system. We have to move it from what is now really not a healthcare system, but a sick care system, into something that is really being proactive and integrative and thinking, as you were saying before, it's not just about what happens once they get to the hospital. How do you keep people out of the hospital in the first place? And virtual care, I was stunned and really disappointed that it didn't continue on its incredible trajectory post COVID. It looked like we had this huge opportunity. It's not too late for us. When you were mentioning ALC, one of the things that was starting during the pandemic, one of our neurologists, Dr. Morris Friedman, created a new program called Virtual Behavioral Medicine, where he works with people in the community via telephone or via video to be able to keep them out of the hospitals, keep them out of ALC. These are people with who are living with different either delirium or forms of dementia and have responsive behaviors that get so hard to manage that they have to become hospitalized. The approach that he's taken is now able to keep about 60% of these people out of the hospital in the first place. And that's increasingly important in a place like Ontario, where so many of our people live in northern and rural areas and don't have good access. I'm spending a lot of time in the Yukon as well. Those folks, if they need a neurology appointment, they have to fly to BC. So taking into account the opportunities we have from virtual care, from all of these remote ways of now being able to monitor people's health and to perform things proactively, I think that's where we're going to see the most opportunity in this collision of technologies and this collision of knowledge.
Laura?
Yeah, I just wanted to rip off a couple of, completely agree with all of that. So one of the reasons we were so effective, well, somewhat effective during COVID is because we had permission to break the rules. So it's time to really have a hard look at the incentive systems. And we are not incentivized to do all the things we've just talked about, that where we know the solutions are. So we have to take a good hard look and dismantle the incentives to not do the right thing, as you said, but actually just keep sustaining a system of acute care. And the second thing, Steny asked about inequities and how we think about that. Well, when we're designing these solutions, if we design them for the most marginalized, the most vulnerable, they will work for everyone. Instead, we usually do it the other way around. We design what's easy and convenient for a few, and then we wonder why there's huge inequities. If we think about it the other way, it will work for everyone from the beginning, and there are established ways to do that.
Okay, maybe you really wanna,
I'll pick up on equity and universality if I can, because equity and universality are so clearly at this point I don't know if they're in conflicts with one another, but they're certainly orthogonal to one another. And when we think about aging and dementia in particular, but you can talk about the psychosocial stuff of cancer, you can talk about child mental health, any number of areas, same thing. We have a healthcare system that pays for healthcare needs, but we don't pay universally for social needs, nor indeed, as a practical matter, could we? And so our healthcare financing systems don't work because we're muddy about distinguishing between universality and equity. And we need way more. That's the other COVID nostalgia, by the way, is what we're starting to call it. But we're another COVID nostalgia thing that we all have going on is the along with virtual care, the ability to break rules, is the realization that we all had around equity and the importance of equity in our systems. But we don't fundamentally say, look, a system that's equitable and that goes out and finds needs-based patients is likely not going to be universal. And a system that's universal, as we know very well, is not going to be equitable. And so how we deal with those trade-offs is something we have to have an explicit discussion about in the social financing side. And I happen to have written a paper on this a year ago, which I'll give you a plug here, with CSA.
great, thanks, Will. Why don't I open up to questions from the audience? Let's see if folks have anything they'd like to ask. Please.
Hi, good morning. My name is Dr. Nicole Nitty. I'm a family physician and chair of the Ontario Primary Care Council. And I just this is an amazing discussion and I really appreciate being here today and listening to all of you. Is the role of the evolving primary care networks in Ontario and across Canada. And when we talk about doing things differently, talking about family physicians, family medicine, and primary care teams leading the way in some of these decision-making and co-designing the healthcare system, because primary care in the family doctor's office, this is where integration happens. This is the main point of integration. And we touch everything. And I think that, some of the, I wouldn't call it innovation necessarily, of primary care networks and building a strong primary care foundation. We've known this for decades. But maybe this time we can actually do it. Because we're talking about prevention, we're talking about health promotion, we're talking about encouraging individuals to overcome their barriers to live healthier. And I think that is where primary care, if empowered to do so, and if they have a seat at the table in system planning, that'll make a big difference. Just any comments around that?
I can kind of kick off, but I'm sure there's lots of us. I think when we talk about the development of a health system, it truly is a health ecosystem that has a variety of partners. But there's no doubt, what we all know is the bedrock to that is primary and community-based care. That's where we have to focus. And the problem, we talked a little bit about this, when we're hospital-centric, which tends to be where our health system starts right now, we're not leaning into that space and that community and primary care based ecosystem. But the only way we're going to manage this work in the future is to lean in and grow and build that primary care infrastructure. It's interesting, when we're talking about equity as part of the work we're doing, and I'm sure this is true for many hospitals around the province. When we looked, for example, we run a very busy urgent care, has over 50,000, it's capitated urgent care, and we still see over 50,000 visits a year. When we dug in, we could see by far our folks who have the greatest economic need in our community visited 2.5 times more. Not a surprise. Guess why? I bet you know the answer. Unattached, right? And so, your quick answer could be build more urgent care capacity. No, actually, let's lean into, really strategic partnerships to build up primary care, build capacity, work with teaching and subspecialty with primary care. That's the answer. So I 100% support that. And just while I have the mic, we've kind of skirted around this term, but I just want to put it out there. We also need, when we're talking about equity, we have to start building a language around digital equity.
Yeah.
Because I think part of the issues around virtual care sustainability really revolved around the lack of digital equity. As a region that serves a lot of rural, Indigenous population, that's something we really found. So I know that's a non sequitur to the primary care question, but I wanted to put it in there.
Because on the district, we can learn a lot from what they've done in California. They recently just passed a law. But on the topic of family care, I think Baycrest is a little different because we're not an acute care hospital. We're a geriatric focused health organization that goes from snout to tail, I guess. Right that way. Trying to get back to your second. But so we have a lot. We have continuing care. We have a lot of community-based work. We have family docs on staff. We have outpatients. We've got dementia daycare. We have long-term care. We've got assisted living. We've got independent living. So it's like we're like the iPhone for aging. We're all things aging in an integrated way. And our Defy Dementia program, you mentioned Nova Scotia. When we were out in Halifax, we connected with all of the family docs out in Halifax. And we recognize, I think that, especially from a planning perspective, for health promotion and prevention, if we don't rebuild the system with the family docs and the primary care in general in mind, it's just not going to succeed. So absolutely 100% behind.
Want to host there? Time for maybe one or two very quick questions. 30 seconds on the question or comment, 30 seconds on the response maybe from the panel. Great, thank you.
Good morning, Amy Capel, CEO of the Ontario Caregiver Organization. I really appreciate the comments that I've heard today acknowledging caregivers. Wondering what your thoughts are around planning for the inclusion and recognition of caregivers as a part of the care team to address this as we go forward. Thanks.
Sure, just 30 seconds.
Yeah, our latest podcast actually is focused on caregiver-centered caring, which is the idea that the family caregivers, whether they're family by birth or chosen family, really need to be integrated as part of the care team, not just within the dementia setting, but in all settings. Absolutely great.
The question?
No reason why the family caregiver, whether chosen or related, can't be included in everything that's going on, and the sophistication levels going through the roof as information gets better, and that's going to continue.
Okay, I'm going to hold this here. I've got one job, which is to make sure you so I'm not going to lie on the question. I'll just say, look, I think what you heard is there's a lot of this report that's valuable. But it also shouldn't be a report that sits on the shelf for 5 years or 10 years and gets redone at that point. It needs to be nimble. I think you've heard about the importance of data liberation, but system at sort of individual level. And I think you've heard that there's not sort of a single solution. I don't know, however seductive or desirable that would be, there's not a single solution, but it's going to need to be a portfolio. We're at the individual and at the population level, but also there's some simple things that could probably be done right now, whether it be the devices we carry around or things you know how to do around the social determinants of health. Or more technologically advanced things that probably still have some time to go, like precision population health and precision medicine. Anyways, with that, it's 8:58, and so I will say thanks to the panelists. Please join me in thanking them. Thanks to thanks to our sponsors, and thanks to Wellwoods, and think you've got 1 minute to spare. Thanks, everyone.